Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Okay, assalamu alaikum guys. We're going to talk about the placenta accreta spectrum, which is guideline number 27A. एक second, मेरा notepad उल्टा पड़ा हुआ है. So basically this is the same guideline for Previa. Okay. Previa का हमने half cover किया था, half हम next session में complete कर लेंगे, and that would be probably on Friday. Okay. So, what is placenta accreta spectrum? We have already discussed in the last video that, okay, what happens is that the placental tissue, the villi, they do not separate after the birth of the baby. And because they are either approximating into the myometrium or they're invading the myometrium to the serosa, or they are throughout perforating the uterine surface and coming out from the other side, from the serosa side, and they are invading the surrounding tissues, the bladder. So one thing which we were talking about in most dangerous seems to be PLACENTA, right? Common sense that this one PLACENTA is going to be most dangerous. Dangerous mein hum na, we're gonna add two crosses. It's going to be most dangerous, okay? And this is going to be requiring a complex pelvic surgery, you know, because it's going to be might be invading the bladder. So, you know, there might be ureteric injury, bladder damage, okay? And might be involving the surrounding gut. There are many cases with case reports on that. Okay, so most dangerous among all of these is PLACENTA, and its management is going to be discussed separately. Okay, Acha, I hope the audio is clear. Clear. I wonder what's happening. Okay, now from the guideline, I have already discussed the guideline yesterday, but now we're going to read it so that you guys don't find it daunting. So let me just get a highlighter. This one, a blue one, calming one, because this accreta spectrum is already very dangerous, so we don't want red color or stuff like that. So what are the risk factors? So the same risk factors as for Previa, as we discussed yesterday, cesarean scar, previous accreta, okay, or a lot of uterine surgeries, or any uterine anomaly, or you know, so we know the history of accreta. Common sense, if there has been an accreta in the past and the patient, you know, underwent a uterus conserving surgery, that's why she's again pregnant, right? Otherwise, she would have undergone a cesarean hysterectomy. So in this case, again, there's a very high chance that in the next pregnancy, she's going to have accreta again. Previous cesarean delivery again, proportional to the number of cesarean sections, just like Previa. Okay, you should know the odds ratio of Previa. What were the odds ratio of Previa? I'm going to recall, you know, everything. Tell me, what were the odds ratio for Previa, guys? Anyone? Let me just open them up. Yes, what was it? It's not written over here. I'm just opening it up. It was 4.5, and then 7.5, and then 6.5. After 7, it was 6. This was the issue. No, in previous 3, it became 6. And then in previous 4, it was 44.9. Please revise it. It's in the same guideline earlier, you know. Previa is mentioned before accreta. You should know these. It's not, odds ratio, it's relative risk. You should know these relative risks on your fingertips. So there are only these 4 values, because the number of cesarean increases, previous 1, previous 2, previous 3, there are increased chances of Previa. And the same thing happens in case of accreta. The values are different, but the same thing, as the number of cesarean increases, the chances of accreta also increase. Okay. So what are other uterine surgeries? What are the other uterine surgeries? Yes, myomectomy, repeated endometrial curettage. That's not a surgery. That's a separate thing. That can also be done as an outpatient procedure. Okay, this I'm going to highlight with yellow that the risk rises as the number of prior cesarean section increase. Same statement is written for Previa also. Okay, same thing the guideline is saying for Previa. Both are siblings. God, what the hell am I saying? Okay, now. So again, how are we going to prevent Previa? We have already studied this. Why are you guys taking time to answer? Why? How are we going to prevent Previa in our population? Yes, by avoiding unnecessary on-demand cesarean deliveries, by by not giving, by avoiding unnecessary scars. My English is broken today, just like my bank account. Both are broken. Okay. God forbid. So, a woman requesting elective cesarean delivery for non-medical indications should be informed of the risk of placenta accreta spectrum. So, if a woman comes to you and she's, requesting an on-demand, let me highlight this with blue, on-demand cesarean section, are you going to do it? You're definitely going to counsel her because it's not indicated and she's demanding it. Of course, if the patient is refusing a vaginal delivery, you can't force her to deliver vaginally. But you still have to counsel her, and when you're taking the consent, you have to tell her in the next pregnancy how much is the relative risk of you having a previa, how much is the relative risk of you having a placenta accreta spectrum. Okay, you're gonna tell her what are the consequences. Maybe she doesn't know about a cesarean hysterectomy. Maybe she doesn't know it exists. But what if next time she comes to you with a placenta accreta spectrum and then she undergoes a cesarean hysterectomy and she tells you, doctor, you didn't tell me. You said it's okay to have a cesarean section. Everyone gets a cesarean section. She's gonna blame you for that. Okay. So you're gonna basically inform her when you are doing an on-demand section and okay, unnecessary. Let's say there is a primary breach, then okay, that's cesarean is an indication for a primary breach. But what if she is totally fine and she is not even agreeing for a trial of labor? Then you should tell her that cesarean is not a good thing. You know what happens after a cesarean? Previa can happen, especially if she conceives again within 1 year. Accreta spectrum hole can happen. Very scary. Cesarean scar pregnancy can happen. Not a good thing. Okay. Okay, wait, guys. Something has come up. Okay, guys. So, what was I was scaring you guys of a cesarean section. That how scary the outcomes of a section can be in the next pregnancy. Okay. So this line is very important that the risk of invasive placentation, invasive, not previa, and now we're going to talk about invasive placentation increases sevenfold after only one prior. This is a very important question. Okay, it can come up as counseling or patient in any of your exams. Sevenfold the risk of invasive. What is invasive placentation? What is it? The whole placenta accreta spectrum. It can be of any extent. It can be accreta, it can be increta, it can be precreta, but the risk increases sevenfold. It's a lot. It's not a joke. After only one LSCS. Tell this to the patient. I'm telling this to you. Maybe you don't know it. Maybe you are not counseling your patients. So from now on, keep this in mind. Okay. So what is the odds ratio? 1.96. Please, we have to keep this in mind. 1.96 after one cesarean section. Okay. So very bad things we have studied up till now. Not good. Okay, everything. Should I zoom in more? I think it's fine. Oh God. It's very difficult if we zoom it in a lot. For me to handle the screen. I'm old now. Okay. So, what is the risk of placenta accreta spectrum? As the number of previous sections increase, it also increases, right? The same thing was happening in Previa. We have the same relationship. As the number of sections were increasing in Previa, as the number of sections increasing, the risk of Previa was increasing. So, in this case, as the number of sections increasing, the risk of accreta is increasing. Now, one very important thing that let me just open the board for explaining it. Where is the board? Where is God? God. Okay. Wait, guys, let me just close an application. It's troubling me. Okay. I need a clean board, not a dirty board. It's not dirty, but I've written a lot of things. So difficult. Okay. Zoom in. Zoom in, guys. Okay. So what was I saying? As the oh God, such a thick ink. What? What, guys? Okay. As the number of sections, number of C sections, CS increases, the risk of PAS also increases. Or a beautiful writing, just saying. But one more thing, that if the patient also has previa, okay, previous cesarean section and also has previa in this pregnancy, both of these things have then to kaam tamam, then to game over now. The risk increases drastically, and then the risk of hysterectomy is going to increase also. Okay, risk of hysterectomy. So you should know all of these relations. Number of cesarean section increases, there's a greater risk of ACCRETA. But if there is a previous scar and in this pregnancy, number of cesarean section increases, the risk of previa also increases. So number of cesarean section increases, risk of ACCRETA and previa both are going to increase. So if in the next pregnancy, the patient is having previa also along with a previous scar, then the risk of ACCRETA is going to increase more. What did we say yesterday? That if you're having a previous scar and if you're having a placenta previa or an interior low-lying placenta, not a posterior. Posterior is also interior. Then you're specifically going to screen for placenta accreta syndrome. What do you mean we didn't know this? What was the screening? When we're going to screen for PES? I told you yesterday, I explained the whole guideline. How are you going to screen for PES, guys? How are you going to? Yes, very good. Very good. So you're going to screen those patients who are having a previous scar with anterior low-lying or a previa. Why? Because in a previous scar with previa, both things are coexisting, then the risk of ACCRETA is going to increase a lot. You understand it? You'll understand it more when we're going to read it now, okay? So the risk of, I need a pointer. Let me get a pen. Okay. What was I saying? The risk of ACCRETA increases with the number of previous cesarean sections and in women with placenta previa and no previous cesarean section, and in women with 3 or more cesarean section. Okay. So if a woman had no scar but had previa, then what is the chance that it's going to be ACCRETA? Very low chance, because usually the tissue invades in the scar side, because the scar side is where the decidua is going to be deficient, because there's going to be fibrous tissue, right? The natural tissue is going to be damaged during the recovery. There's going to be scar tissue. So if there is no previous scar, then where is going to the placenta? Where what has happened to my English? I'm sorry, guys. Where the placenta is going to invade, right? So the risk is going to be over here 33.32 incidence, sorry, not risk, 3.3 to 4%. You guys have to memorize this. I'm sorry, guys. Okay, just remember 4%. Okay, so basically if there is no previous scar, then the incidence of ACCRETA in a previa is 3.3%. But if there are 3 or more scars, then the incidence of ACCRETA in a previa is 50 to 67%. Oh my God, the risk is increased. The risk has skyrocketed again. Now, the odds ratio in a subsequent pregnancy, it ranges, okay? So It's 8.6 and 17.4 for 2 scars, previous scars, and 55.9 for 3 or more previous scars. Okay, these values I can't memorize. So if you can memorize, then do. If you can't, then please, have mercy on yourself and try to understand the whole concept and only memorize those things which I am requesting you to. Just do, that would be great. Okay. So what we have studied that the if there is no previous scar and only previa, then what is the risk of ACCRETA, incidence of ACCRETA? 3.3 to 4%. Okay, 4%. But if there are 3 scars, then it's let's memorize 50 to 67%. 50 to 60 we can memorize, 4 we can memorize. What's the rocket science? What's the trouble? No trouble. Now, so this means that previa is a risk factor, right, for placenta accreta spectrum. Okay. For women who have previa and a prior C-section, the risk of accreta increases. Okay, when there is one scar, okay, when there is one scar and there is previous and there is previa, then what is the risk? 3%. For 2, there's 11%. For 3, it's 40%. For 4, it's 61%. And for 5, it's 67%. Okay. Have you ever seen a previous 5 scar? I have only once. Usually women undergo BTL or, they go on some solid contraception. They don't want a 5th scar because after that they're going to become a previous 6 scars, which is horrific just to imagine what is going to be the condition inside. Too much of fibrosis. But I have once. Okay. So, no, guys, that story time is for a separate time. Okay. I'm not going to tell you the story of that previous 5 scar. So, what was I saying? So, see, you should, it's very easy when both are coexisting. Okay. Both are coexisting over here. If there's only a previous scar, then what is going to be the value? But then what are going to be the percentages? I think they were above. Okay. Let me show you guys. Okay. We'll come to them. You just keep these in mind. They are important. These figures, they come in MCQs. These two especially. Let me show. Previous 3, previous 4, and previous 5. This 40%, this 60%, and 67, they are from the MRCOG recalls. Okay. So 40% is the risk of accreta when there are previous how many scars? When there are previous 3 scars and previa, and when there are previous 4 scars and previa 61, I'll write them in the board, don't worry. And then the previous 5 scar and previa, then 67%. Okay, very easy values. So let me ask you guys a quick question. Yeah, beautiful board again. You guys are scared of the board because there's going to be a question? Okay, great. So the question is that what is the incidence of accreta if there's only previa without a scar? I just told you guys. I told you to remember one figure. Yes, very good. Good job. It's 4%. Okay, it's 4%. And what is the risk of PAS? We're going to call it PAS. If there are 3 or more scars and previa also. 50 to 67%. Same figure we have seen, right? Basically, the same values we're just reading over here, 61, 67. So 50 to 67 was the right range, okay? They had mentioned this before. Let's get back to the guideline. Okay. So incidence, I said 1 to 200 to 1 to 300 to 1 to 1 by 1000. And what was the incidence for Previa? It was 1 per 200. Okay. So what are the additional factors? We have discussed so much about scars and Previa as a risk factor now. And we know the values, the value of 4%, the value 50 to 67%, and the other values of 40%, 61, and 67%. We know these values, right? So maternal age was also a risk factor for Previa. And Previa is a risk factor for ACCRETA. So that's how you can keep that in mind. Maternal age is also a risk factor for ACCRETA. ART was also a risk factor for Previa. Now in ART over here, IVF specifically, they have mentioned. So when we are talking about advanced maternal age, we mean 35 or more, okay? So now we have a very important value that 35 or more without a previous scar, okay? The ratio, odds ratio increases by 1.3 for every 1 year increase in age. It's a very scary line, right? So if you're old, it's gonna scare you, but it's okay. With after 35, with every 1 year, so you become 36, it increases by 1.3. You become 37, it increases further by 1.3. So for every 1 year increase in age, this is not very important. It's not. It might come in a question later, but up till now, I haven't found it. Okay. So as I have told you, that ACCRETA spectrum, it's not just because of a cesarean delivery. You know, I have mentioned cesarean so many times, but I have also said that ACCRETA can happen in Previa without a scar. So the presence of a scar is not necessary for this spectrum to happen. But scar increases its chances, you know, sevenfold increase in the incidence or in the risk with one scar only. So cesarean scar is an important risk factor, but it's not the only risk factor, okay? We have already talked about that, right? So what else is the risk factor? Other surgical trauma, you know, it traumatizing the uterus is going to traumatize you back. So you are, you know, bothering the uterine endometrium. The endometrium is going to bother you back. A superficial myometrium, it's gonna bother you back. So you're gonna doing a lot of curetages, or when you're manually, this is very important, manual removal of placenta is specific to ACCRETA. It's not specific to Previa. So please keep this in mind. Postpartum endometritis, because it's going to damage the endometrium to an extent. Myomectomy, common sense, okay? These are all, you know, associated with ACCRETA. So the odds ratio, azan break, guys, azan break. Okay, guys, so we were talking about the risk factors. So I had already discussed them in the, you know, explanation video yesterday. So we're gonna, you know, have a look at them from the board again, that if there's a history of ACCRETA, if there's previous section, if there's a previous scar, then what is the risk in the next, after one scar, sevenfold increase of ACCRETA. Very good. And it's already written. And as the number of sections increase, the number of previous scar increase. And also Previa is a risk factor. I think I have not written Previa because it's common sense, but Previa, whether it's with or without a scar. When it's without a scar, then the risk is 4% in the incidence. And when it's with a scar, then the incidence with 3 scars, it goes to 50 to 67%, 3 or more, okay, with Previa. So uterine surgery, if the patient has undergone repeated curetages, a myomectomy, or if they have been postpartum endometritis, or the patient is basically increase in like there's a great maternal age, 35 or more, ART, specifically IVF, has been mentioned in the guideline, or the patient has underwent manual removal of placenta. Cesarean scar pregnancy. the dilemma, the scary, scary thing which we are going to tackle in the guideline of ectopic, very beautifully written in the RCOG guideline. Okay. So in cesarean scar pregnancy, in the second half, we do TBS, and that's how we diagnose. And it's common sense that if pregnancy is inside the scar, of course, it's going to invade. So there's nothing surprising in having a ACCRETA and a cesarean scar pregnancy. That's why you should terminate it earlier. If you're continuing with it, then ACCRETA and invasion will worsen, and then you'll have problems. Then you'll have problem, guys. So, how are you going to now diagnose and suspect it? Let's get back to the text. Okay. So, how are you going to suspect it and diagnose it? So, antenatal diagnosis is very important, common sense things. And if the patient is having a previous scar, the patient is only having a previous scar and the placenta is not low-lying, it's not previa, then you're not going to screen. So, this is very important. And when are you going to screen the patient? When there are two things. I'm repeating these again and again because these are the most important part of this guideline of PAS. If there is a previous scar and there is the presence of an interior low-lying, not posterior, okay? Interior low-lying. The specific points for posterior are separate, okay? They're also discussed. And or there's a previa. With previa, we're not talking about interior or posterior. Okay, with low lying, what was the definition of low lying? Within less than 20 mm radius of the internal os, but not covering it. And what is the definition of previa? Covering the os, whether completely or partially, right? So, guys, let me check if we are recording. Are we recording? Yes. I'm sorry. Okay, so a placenta previa should alert the antenatal team that the patient is at high risk. So you should screen the patient for PAS. Okay. And what is the mean maternal complication is because of massive hemorrhage, and the estimated blood loss is from 2,000 to 7,800. That's a lot, God forbid. And the median number of units that had been, transfused is 5. That's a lot. And so why am I scaring you? Because this is why antenatal diagnosis is important. So you're prepared. You're not delivering the patient without a specialist. You're not delivering the patient without people who are experts in complex pelvic surgeries, without ICU, without neonatal ICU. You're not. So if the patient is not diagnosed and you open up and you find PLACENTA, you're not supposed to proceed unless you are in a safe place. You're supposed to close the abdomen. If you have not touched the uterus, we're going to discuss it later. Or if you have delivered the baby, after delivering the baby, let me just open the board. Okay. Let me just open the board. So if you have not diagnosed, antenatal diagnosis is very important, but you have failed to diagnose. Sad thing. Patient comes to you, or an emergency, and you open up and you just open the abdomen. The uterus is here, and you find that the placental tissue is all over the place. Okay, it's all over it's like, hello, doctor, I'm chilling out here. Do you want to perform the surgery right now? Hello, nice to meet you. I am outside the uterus. I'm all over the bladder. You're not supposed to try to become a hero. You're supposed to close the abdomen again. This is what the guideline says. Close it again unless you have all the requirements for, the surgery of PLACENTA. PLACENTA, very dangerous. Okay, so PLACENTA you have seen you already visualized because it's outside, it's greeting you dangerously. But again, if you have a patient and you have the uterus is open now, okay, is this how an open uterus looks? Okay, here's the uterus. Okay. and you have just, just delivered the baby. The baby's outside. The baby's like, wee, I'm free. Time to party. I'm in the world. The world is exciting. Baby doesn't know about education and unemployment and financial issues yet. Well, and now you, the surgeon, you're like, oh my God, the afterbirth is not separating the placenta, the cord. It's not separating. Shit. Oh, I was supposed to draw the eyebrows, monobrows. Shit. What am I going to do now? What are you going to do? You're simply not separating. It's ACCRETA. You know this. Do not try to be a hero and try to separate it when you know it's adherent. The whole of the placenta is not going to be adherent. Some portion of it's going to be there. Okay, it's very rare for a whole of it to be adherent. So you're gonna easily know that this is ACCRETA. The rest of it's separating, but this portion is not separating. So do not try to pull it and lead into a massive. Just simply stop, close, leave the placenta over there, and perform a cesarean hysterectomy, because right now you cannot do anything. You have already delivered the baby. The patient is already open. The hemorrhage is already going to happen. So you have to remove the uterus with the placenta in situ. Do not try to attempt any stupid, emotional, heroic measures which are not mentioned in the guideline, because that, my friend, would be a crime. The first crime is to not to understand the guideline, and the second crime is to do things without any knowledge. There are two crimes in obs and gynae, guys. Do not perform them. So you know that you see if it's antenatal diagnosed, if it's antenatally why am I stuttering? If it's antenatally diagnosed, maybe I'm scared of the whole scenario. I'm imagining it in real time. So then no issue. You already knew. You're already prepared. The 6 points which we'll study of the care bundle are present, are fulfilled. But if it's not until diagnosed, and you have these two situations: without delivering the baby, without incising the uterus, you're gonna do this. If you have incised the uterus, if you have delivered the baby, then you're gonna do this. Okay, there's two scenarios over here. Now let's get back to the text. Too much of talking we have done. Now, undiagnosed before delivery, still if you do the screening, still overall there are 1/2 to 2/3 of the cases are undiagnosed. I have mentioned this yesterday also. Please keep this point in mind. 1/3 were not diagnosed, so 1/2 to 1/3 to 2/3, 1/2 to 2/3 remain undiagnosed. This is a lot. This is a lot. Okay, sorry. Okay, so what do you need for placenta accreta spectrum? We're going to study it in detail. Okay, so how do you screen it? Ultrasound is highly accurate. It's not, MRI is not superior to ultrasound, but the requirement is that it is performed by a skilled operator. This is how they confuse you in the MCQs, that they mention that a skilled operator is not there for scan, but a skilled operator is there for MRI. What will you do? And you are like, no, the guidelines said that ultrasound is highly accurate. You just, you had ADHD and you just study over till here. You didn't study the whole line, and then you performed the MCQ wrong. I'm just scaring you so that you don't do it, okay? I'm like, gladly you're not sitting in an exam right now. I'm here to help you guys. So please read the whole line, because this is where the questions come. You should know when you're going to do an MRI, when you're going to do an ultrasound. If you have a skilled operator, then you don't have to do an MRI. You're going to go for ultrasound. But let me again open the board again, because it's a very important concept for the placenta accreta spectrum. This is the whole point of this guideline, where they're going to confuse you, and then you're gonna, remember me. So basically what happens, I'm telling you guys, children, please have patience and listen, okay? So the thing what happens is that, what was I saying? Okay, so if there is, usually you have to do ultrasound. If you have a skilled operator, okay, there's no doubt in that. If you have a skilled operator, do an ultrasound. But if you are basically You want to assess the lateral extent. You have diagnosed it. Now you want to see for the lateral, for diagnosing, you can do ultrasound, but now you have diagnosed, now you want to see the lateral extent. It's not clear by the scan, or you want to see the parametrial invasion. Usually for posterior previa, this happens that, see, I said that there is one point for, what was the point for anterior? For anterior low lying, that for anterior low lying with a scar, you have to screen for PES. It is not mentioned for posterior low lying. For posterior low lying with a scar, we also have to screen, but it's not mentioned in the guideline. But we still do it because we are anxious and we'd like to do things prophylactically. We are scared. But in the guideline, for anterior low-lying placenta with a previous scar and for placenta previa, you have to screen for PES. This is one point for anterior low-lying. Now, there's one point for posterior low-lying or for posterior previa. For posterior, it's not very, nicely visualized by scan. If you have issues with visualization, then you can go for MRI. So you're not supposed to go for MRI every time there's a posterior PES. Only when there is limited visual acuity, or when there's limited visual access, because it's posterior now, so there are many structures interior to which you're gonna have trouble with its scan to look at its invasiveness. So it's very natural for you to require something else, so you're gonna need an MRI. So MRI is going to complement your ultrasound findings to find out the lateral extension. For parametrial invasion cannot be seen by a scan. A scan fails at parameter. Always remember, so in order to see the parametrial invasion or lateral extent, you're going to need an MRI. But if you can already see, you're already clear about the lateral extension, then you don't have to perform an MRI. So you don't have to perform an MRI every time after a scan, but you have to perform it when you have these issues. When you're having trouble with the lateral extent, you're having trouble with the parametrial invasion, you're having trouble with the visual access for a posterior one, okay? I hope the concept is clear. Thank you, guys. I know I teach well. Where is it? Let me just show you again what we studied yesterday. Let me put color. So similar, okay. Complements ultrasound imaging. MRI complements it when you why am I stuttering? My English is gone today. When you need to see the depth of invasion, when you need to see the lateral extension for posterior placentation, these two P's, the two P's require an MRI. So the question is, what are the two P's of PAS? Should I write it down? It's going to take a lot of time, but I think it's going to stay with you guys if I write it down. I wish I could just type it. Someone type it in the chat box. Great. You guys are slower than me. What are the two P's for MRI in PAS? What are the two P's? Wait. Okay, sorry, I had to mute or something. So what are the two P's? Yeah, guys, in PS. PS has been diagnosed. Diagnosis is done. Now, if there is posterior placentation, right? If there's posterior placentation, or if there is, sorry, guys, or if there is suspected parametrial invasion, you must do an MRI, okay? And when does an MRI complements a scan? When does it complements with a different color, so that you can just keep in your mind. When does it oh God, I'm so bad at writing. When does it complement ultrasound? When does it complement ultrasound? When you're seeing the lateral extent, and where is it? When you're seeing I forgot. That's why I had to go back. So when you're seeing the depth of invasion and when you're seeing the lateral extension, that's when the MRI complements the ultrasound imaging. What do you mean by this? Someone explain this line. That Yes, very good. This means that for assessing the depth of invasion and lateral extension, it's not necessary to perform the MRI. But if you're having any confusion or if you're having any limitations, or if you want to confirm the ultrasound findings, then there's no harm in performing an MRI. Okay, the radiologist, the sonologist won't be offended that I performed a perfect scan. Why are you ordering an MRI? You're going to show him the guideline. You're going to say, look at the guideline. I'm supposed to complement the scan with an MRI when I want to assess the depth of invasion and lateral extension. What's wrong with you? Haven't you studied the guideline? Okay. And too dramatic, guys. Please just cut it. Okay. So, and when is it necessary? With the two P's for posterior placentation and for parametrial invasion. Great. Let's get back to the text. What is this? Okay. So, a woman with ultrasound features suggestive ACCRETA. So you have to refer to a specialist unit with imaging expertise. What if you start performing the ultrasound? Then, guys, you're literally malpracticing. You're not supposed to diagnose it. Okay, you suspect it. You're supposed to refer the patient to someone who has expertise in scan. Okay, or in MRI, any of two. No one is superior to the other. So, who are going to be screened specifically? We have already, please someone answer this. I'm really tired of repeating again and again. I have gone old. I have repeated it 100 times that when are you going to screen for PAS, previous scar with an anterior low-lying or a placenta previa? And what are the two P's for an MRI? Very good. That was a very fast answer. Posterior placentation and parametrial invasion. So when we are performing a scan, again, let's go to the board. God, I think we'll have to end the session. I'm really tired and we haven't completed much. What the hell, guys? It's because you guys are not answering quickly. I have to repeat everything again and again. Okay. So what are the ultrasound methods? We have grayscale method, we have the CDI, the color Doppler, we have the 3D power Doppler. We can combine grayscale with any of these two also. What is the sensitivity of ultrasound? Hurry up. We studied this yesterday. We're just revising the board. Hurry up. 90.7%. And what is the specificity? 96.94%. And great. And what happened? When does the predictive accuracy of ultrasound increases? Hurry up. When does it increase? I told you guys yesterday, high performance when Previa and previous one coexist. When the combination of Previa and previous one coexist, then there's a higher ultrasound performance and the sensitivity and specificity, they increase to 97%. Earlier, the sensitivity was low. Earlier, the sensitivity was 90.7. The specificity was almost 97 already. But when there's a combo of previous one and Previa, both are present, then in that case, the first thing is that you're going to screen. And the second thing, the sensitivity specificity increases to 97%, both of these. So this is a very important MCQ point. You guys have to keep it in mind. And I am really tired now. Let's just do one more page. Okay. No, there's no time for break, guys. Abnormality of the uterus bladder. Okay, this is another question. Again, get back to the board. Opening the board the 100th time. Which ultrasound feature has the best specificity and which ultrasound feature has the best predictive accuracy? Who is going to answer that? Please answer that. Otherwise, we're not going to move forward because it's a shame if you guys can't answer that because we studied that yesterday, guys. Very good. And which ultrasound feature has the best predictive accuracy? Very good. So best specificity award goes to abnormal uterus bladder interface. I showed you guys this yesterday, right? 99.75%. I have written this. I've written this. If you guys can understand over here, it's written. Abnormal UB interface And which feature has the best predictive accuracy? I haven't written this. Abnormal color Doppler vessels. This is common sense. Of course, when there is abnormal placenta invasion, then there are going to be abnormal tortuous feeder vessels, and there's going to be an increased blood flow in that area. So there's going to be an abnormal vasculature. What's the hype with this? I don't, most of the points in guidelines are just crude common sense. And those are the points you guys fail to answer. That's really, something, a mystery I can't solve. Very good, guys. But you guys answered it quickly. Uterus bladder interface, the abnormality, a best specificity, and the best predictive accuracy goes to the abnormal vasculature, 90.7% sensitivity, and specificity of 87.6. You have to memorize these two things. Potential questions, you have to memorize these two things. So women who have placenta previa and a history of prior cesarean section, the performance of ultrasound increases. I have already told you guys, the sensitivity was, what was the sensitivity before? Hurry up, guys, answer this question. I'm going to end the meeting. Don't just, very good, 90% almost. And what was the specificity? 97%. And when there's a combo of previous one and previa, then both of them increase to 97%. Okay, so then we have this another feature, which is we're done with this, right? We have understood? Understood. So moth-eaten appearance on grayscale imaging and increased vascularity of placental bed. These are the most common. This is also a question. So I told you 1 point is for best predictive, the feature on ultrasound with the best predictive accuracy. The feature on ultrasound with the best specificity. The third point is the most common ultrasound sign. Number one is the moth-eaten appearance, and number two is increased vascularity of placental bed. These are the most common. Okay. Okay. Now, we have to determine, once we have diagnosed, we have to determine the depth and the lateral extension. That's common sense. You can't just let the patient go. Hello, madam, you have PAS. Now please go. No, you can't do that, right? You can't even imagine doing that. Depth and lateral extension is very important so that you can plan accordingly, okay? Because that's going to tell you whether it's increta or percreta, what is it? It's not, the 100% you can only be sure when you open the patient up during delivery. But, imaging can help you, get an estimate. So no ultrasound sign or a combination have been found to be specific for the depth, okay? So for these things, you need an MRI, okay? This is very important. This is for depth. For diagnosis, ultrasound is good, but for depth and lateral extension and for, no, you don't have ultrasound signs for that. So it's a very important question. They can confuse you that what is the ultrasound sign for specific to the depth of accreta, decreasing echogenicity along the myometrium, stuff like that. And if you haven't attended my course, then sadly you won't be able to answer that question. So as the vast majority of accreta spectrum and other consequence of low, okay, we know that previous scar presentation and previous scar size. So TVS has a role, and differential diagnosis between adherent and invasive accreta presentation and management. TVS does have a role, but there's no specific sign for depth. I'm going to write this down on the board. It's going to take some time, but it's worth it. It's really important. I'm going to add one more question to the board. Hurry up and answer it. I just mentioned it. The question is, wait, guys. The question is, most common ultrasound features. There are two features. Very good. You guys predicted it. What I'm going to write, you guys answered it already. I'm very proud of you. And the next question is that role of ultrasound for assessing, what a bad writing, but we don't have time, assessing the depth of PAS, and the answer is a cross. There is no role. sadly. Do I sound like Trump? Oh, guys, what the hell? Where is my screen? Okay, we get it? I'm literally now unable to talk properly. I'm so tired. Okay, my recording. I'm back. Okay, so we just talked about the beautiful features of the ultrasound and the failures of scan that, cannot assess the depth. Poor ultrasound cannot help us with posterior presentation, with the parametral invasion, with the assessment of depth. I think with assessment of of depth is the same thing as parametral invasion. So scan fails at both of these things. But it's okay, guys. We're not going to call it a failure because there are many things we also fail at. Okay. So what is the diagnostic value of MRI? It's similar to ultrasound when performed by experts, but it's going to complement it in case of assessing the depth and the lateral extension, especially with posterior presentation or ultrasound feature. Ultrasound can suggest parametral invasion, but once you have suspected, keep this algorithm, once you have suspected, how we're going to suspect it, I'm going to tell you guys later. It's a separate discussion. But when you have suspected parametrial invasion on scan, you must do an MRI. So there are certain situations, the two P's are the situations where you have to do an MRI. Okay? Okay, we get it? So MRI has been increasingly used for prenatal diagnosis of placenta accreta. The main MRI features are, what are the main MRI features? Abnormal uterine bulge, it's very beautifully seen. A dark intraplacental band, heterogeneous signal intensity, disorganized vasculature, disruption of these are all some things you are only going to understand when I show you guys. There's no point in just reading them. So I'm going to show these to you guys, okay? When? Not right now, okay? I'm sorry. A systemic review has found out that most studies, okay, this is a very bad point. I really don't, what's the broad range, okay? What is the sensitivity of ultrasound? 75 to 100. I'm talking about ultrasound. Are you guys sleeping? Very good. 90%. What is the specificity? Very good. 97%. And what is the sensitivity and specificity of ultrasound when there's a combo of previous one and Previa? 97%. Very good. So what is the sensitivity of MRI? 75 to 100. What a broad range. Can you trust this? I found it very fishy, very sus, as you guys call it. And what is the specificity? 65 to 100. Please memorize this. Okay. So MRI has a very high predictive accuracy in assessing the depth and topography of placental invasion. This is a very important point. Okay, so we have some other things to increase the specificity. What was increasing the specificity and specificity of ultrasound? Just a combo of both previous one and Previa. What a stupid thing. But the use of IV gadolinium injection is increasing the specificity and sensitivity of MRI in the diagnosis of invasive forms of placenta accreta spectrum. Okay, but we don't know if these gadolinium injections are affecting the fetal safety. Okay, very important point. And the most important thing, the experience of radiologist is an independent factor in the diagnostic accuracy. This is a very important question. The experience of radiologist is an independent factor in the diagnostic accuracy of MRI. Okay. So next point is how we're going to care for them. Typical answers in our, we have MDT, multidisciplinary team. You should have a specialist center with blood products, with adult ICU. Very scary, but you should be ready. There might be a hemorrhage and consumptive coagulopathy. There might be a disaster. I'm sorry, but there can be. Be ready for the worst. And ICU expertise in complex pelvic surgery. A gynecologist, urologist, general surgeon, everybody should be there. It's going to be a jam. Okay, placenta percreta can be associated with percreta is very scary. Placenta is everywhere. Placenta is waving to you outside the uterus. You open the abdomen. Placenta is like, hello, madam. And you're like, oh my God, I don't want this. Okay, so uterine rupture can happen, bladder involvement, life-threatening hemorrhage. All these are common sense. And with that common sense, I'm going, guys. We'll continue it later. I have to go somewhere. How do I